Hello, my name is Rachel Sayre, and I'm the Heart Disease and Stroke Prevention Coordinator for the South Dakota Department of Health. And I'd like to welcome you to the third of a four-part webinar series on quality. In today's discussion, I'd like to let you know a little bit more about why this webinar series was developed. In January of 2016, about 24 healthcare professionals began developing a strategic plan for cardiovascular health. It was finalized and implemented in 2017, and the current version of this plan is what you see here, and it can be found on the South Dakota Department of Health website listed in the web links box. During the process of developing the strategic plan, 4 different goal areas were identified as denoted by the different colored columns. Each of the 4 goal areas has a work group focusing on the area's designated strategies. The first thing the prevention and management group decided to concentrate on was encouraging the implementation of quality improvement processes in health systems. Before the group could figure out how to do this, they had to first establish a baseline. So a QI assessment was completed via email survey. Results indicated there is a wide range of knowledge, staffing, and implementation of QI throughout the state. There's also evidence that there is a disproportionate amount of resources available to facilities depending on their location, size, affiliation with the health system, etc. So based on the survey results, the work group decided to compile a list of resources already available related to quality improvement and house them in an easily accessible place on the Department of Health website. After completing that, the work group decided to expand this resource guide into a toolkit, which will include further information related to the QI process, as well as case studies and additional helpful materials. This webinar series has been developed to supplement that information included in the resource guide and the toolkit being developed, and to serve as a platform for professionals across the state to promote discussion around QI needs, to encourage partnership between the organizations, and to provide an opportunity for our successful QI initiatives to be showcased so that we can hopefully spark similar projects across the state. During today's webinar, we'll hear how quality improvement initiatives are implemented in rural areas. First, we'll hear from Leanne Kaufman on Huron Clinic's new self-measured blood pressure monitoring program. And then we will hear from Susan Johansson regarding quality improvement in the primary care setting, addressing diabetes, which we all know is a common comorbidity among those diagnosed with cardiovascular disease. So we'll start out with Leanne. She is the clinic administrator at Huron Clinic, and Leanne has been at Huron Clinic for over 20 years. So she started when she was 18. She's trained in laboratory technology and worked in the field as a laboratory tech and laboratory manager for 7 years before moving into the clinic administrator role as of January 2004. Leanne believes that implementing programs to assist the patients of Huron Clinic and their community in preventative medicine and their healthcare needs is essential. So I will turn it over now to you, Leanne.
Okay, thank you very much. And yeah, I think maybe I was 16, not quite 18. But anyway.
Yeah, that sounds about right, yeah.
All right, so we have been very fortunate to get to be in a program for self-monitoring blood pressure for our patients in our community. Along with, it's been a collaboration of people in which Rachel Sayre, Kevin Atkins, and Holly Ahrens have been very supportive, met with us on a monthly basis, and help us to create everything that we've done from the bottom up here with this program. So beginning in February of 19, we started this quality improvement program to reduce the blood pressures to the NQF 0018 standard of 140/90. And like I had said, it's been a collaboration of the people and groups to establish this program. We are fortunate to have received self-measuring blood pressure machines from the Department of Health in both medium and large cuffs, which we can distribute to patients of newly diagnosed hypertension, uncontrolled hypertension, and it's been a great program for us. The providers are the ones who determine which hypertensive patients are eligible for these blood pressure machines to take home. We're doing it in 2-week intervals with extensions as needed by the provider. The blood pressure guidelines have been addressed to the patient, and they want them taken twice a day and recorded. There's a website at the bottom of which we utilized to create our instruction sheet of how to take the blood pressure that we want to send home with the patients. And we've created a logout for our machines and our blood pressure flow sheets that go along with the patient. So our discussion for our goal with our providers was to meet that guideline of 140/90 for our patients. Understanding that the American Heart Association is moving towards the 130/80, but our providers felt really strongly that that goal number was too low for especially the number of elderly patients that we have in our community, which creates an increase in risk fall for those people. Reduce the number of patients with the white coat hypertension to improve our numbers by giving them time to relax prior to taking that blood pressure measurement. Or sometimes taking a second reading after they've been sitting for about 10 minutes or later on in their appointment time. So our goal is to get all providers in our group to an 80% goal of less than 140/90. The data from pre and post this implementation. I mean, we're not complete yet, but we began our program and we only had a 60% average for all of our providers. And that's as a group, not individually. Provided the nursing staff with an overview of blood pressure monitoring protocols and had those same discussions with providers at medical staff meetings, reviewed the blood pressure results for the patients who have returned those blood pressure monitors with their respective providers. We did this at a staff meeting along with individually with the providers. Those are scanned in and kept as a permanent part of that patient's record. But as of yesterday, we can say that we've made great progress in that we are now at 77% satisfied in this measure. So everybody has really dug in and made this a good new protocol and self-monitoring blood pressure for our patients. So now we move to community involvement, in which we're going to partner with the Dakota Provisions in Huron. They are the largest employer in Huron, and we want to bring awareness to those employees. There is a language barrier because greater than 50% of those employees speak a language called Karen, and they are from Karen. They're from either Burma or Thailand, and they were brought here from a refugee camp and started working at the turkey processing plant. So there's a big barrier there, in which we've been fortunate enough to send a Karen student to medical assistant school who now works for us. And we're going to send 2 nursing staff out to the plant at Dakota Provisions one of which of them speaks Karen, in early May, and a couple different times during the day. We're going to try it for one day first to share the information about hypertension and to offer free blood pressures. A lot of these people have never had a blood pressure taken ever. So it's going to be an experience, but we're up for it. We want to challenge ourselves to see if we do find some new hypertensive patients, that we can get them under control. So, so the machines for the blood pressures we will take out there. We also will take some manual blood pressure cuffs at the same time. Hopefully showing some of those patients how to take their own blood pressure with the self-monitoring blood pressure machine. And then we'll see if there is an additional date that we will do in the future. So that's kind of where we're at with our program. And we're glad to help in any way for our community to increase the awareness for hypertension and to meet our goal. And hopefully we meet our goal of 80% within the next couple months. So thank you everyone for your time.
And as Leanne mentioned, my program's been working really closely with Huron Clinic on this initiative, and it's been fantastic how quickly the providers and staff have gotten on board with this. As you heard, they're already seeing improvements in their blood pressure performance measure, and you know, it's been very helpful with identifying those folks that are leaning more towards the white coat hypertension than actual true hypertension. So a lot of great outcomes we're seeing here. And I just want to mention also that Betty Crandall's information is up on the slide here. She didn't present with Leanne today. Leanne did that, but she is available for questions and has been very instrumental in the work that they're doing. She's their health home coordinator and has been helping a lot with these projects. So she's also available along with Leanne for questions. With that being said, I'll open things up now for any questions or comments that you might have. And just remember, you can type in the chat box at the bottom right side of the screen, or you can just unmute your phone by pushing *6. And I can get things started with the question for Leanne and Betty. What would you say was the hardest part of getting that self-measured blood pressure monitoring program up and running?
So initially, to start with, was to find the tools that we needed. And once again, I'm going to give Rachel a big plug here because she's the one that was instrumental in being able to get the self-monitoring blood pressure cuffs from the state for us to use. That was huge. The other thing was when that other guideline came out to be the 130/80, our providers kind of dug their heels in at that time. And so to be able to let them utilize that 140/90, really then they grasp onto this program. So
That's great. I know that we've already seen your performance measures changing, but have you noticed any other benefits either for your providers or for your patients?
okay, so I just have to say it. Competition in providers is good. And when I say competition is good, what I mean is when they actually can see all the numbers and compare their number to everybody else's, they tend to compete to, get that hypertensive patient back in. recheck their blood pressure, be one of them that wants to send out that self-monitoring blood pressure cuff?
That's great. And Leanne, there's a question. You know, you are among the leadership, of course, in the clinic, but was there anything that you had to do to get buy-in from the other leadership within the clinic for this program?
You know, Rachel, it wasn't so much of trying to get the buy-in for that leadership, but that 140/90 goal instead of when initially we had said to them 130/80. Like I said, they kind of dug their heels in, but now the 140/90 is something they feel that it's achievable and doable for the patient. So I think that was getting their buy-in.
So helping just make it a more achievable goal definitely helped with that buy-in from providers. Thank you. Any other questions for Leanne or Betty while we still have a second? I see a question coming up here. Leanne, any feedback that you've received from your patients?
So we haven't had a lot of feedback from the patients. One thing, and I don't know, I'm sure all of you are aware of this, but we used to bring our patients in for free blood pressures, so they could walk in any time of the day and do those. Well, we found out that when you're looking at these NQF guidelines and things and how they count in the measure, that a service that wasn't done by the provider or billed out as an encounter doesn't count. Therefore, we now have started doing some minimal visits with our providers to do these blood pressure for our hypertensive follow-ups. And we thought maybe we'd get some kickback from patients about that. But I almost think that they're feeling, you know, my provider really cares. They want to make sure my blood pressure is under control. Maybe they made a change to my medication or to my diet or exercise, and they really want to see how I'm doing. So I think that's the feedback. It's positive feedback that we're getting.
That's great. Thank you. Now I'm going to turn things over to Susan Johansson, and she is the Diabetes Coordinator for Avera Medical Group Quality in the Quality Department, where she focuses on diabetes awareness and systems change to improve outcomes and educational opportunities for providers, staff, and patients. Sue has held various roles, such as with the South Dakota Department of Health as a community health nurse, managing a home health agency in a small rural community, and with the South Dakota Foundation of Medical Care, working with communities to form coalitions to improve patient outcomes and communication. Additionally, she serves on various work groups around chronic disease and diabetes in the state. She is a graduate from the University of North Dakota Nurse Practitioner Physician Assistant Program in the early 1990s. And now we will pass things over to Sue.
Thank you for allowing me to participate. And when I opened, I said we were no longer going to talk about those of us who are over the age of 50. So Leanne, remember that. So I want to tell you a little bit about the diabetes model of care that we've developed. So just to make sure that you remember that diabetes is in our Avera population about 35,000 individuals who are currently diagnosed with diabetes. South Dakota's population number of 860,000 also shows us about 9 to 10% of those individuals have diabetes. South Dakota is very unique, and the fact that we have such a difficult time delivering educational information, our location, our geographic size, the availability of providers, our provider time and constraints, not to mention the costs associated with diabetes education. You know, diabetes education has not only the general cost, but it also has an out-of-pocket and a deductible language that goes with it. Quality measures associated with our providers include things like A1Cs, cholesterol, eye exams. We look at hypertension control. And so most of our insurers at this time are really focused on diabetes measures to assure that we can get those improved and we can see some increases. Generally, our A1C values for most of our insurers run about a 9%. During the time that they hired me at Avera, they were beginning to look really diligently at diabetes overall, the system, and what they realized is that there was very little educational abilities beyond our Sioux Falls area. So when we began, I went to 23 different clinic sites, and at those clinic sites, what we talked about was what providers needed. Not surprisingly, those providers indicated that they needed a couple of things. They wanted a CDE in their clinics, which obviously is virtually impossible, but they wanted some standardization of not just printed materials that they were currently using, but also some standardization of the education offering. We then proceeded to do a record review of about 400 individuals, and what we saw was overall that about 75 to 80% of the individuals that we reviewed had never received a formal diabetes education program. So because of that, we started to have that conversation with the providers and with regional leadership. We looked at what were traditionally offering. So we looked at the diabetes center programs. We looked at some DPP programs. We looked at the fact that we had persons in Pierre that were interested in starting a program, up in Aberdeen program. And what we realized is that we had areas in the very rural spots that didn't have anything to offer except maybe a nurse who was able to provide some information. So what we did was we went to our primary care service line, and we'll talk about that in a little bit, but we were able to go to those regional directors and discuss options associated with that approach to education. We looked at the things that would be most logical to do. We had one particular regional director who was extremely interested in putting his education together. He had some new mid-level providers that were less busy than they could have been, had some time that they could allocate to education, and were all extremely interested in diabetes education. So we looked at how we might be able to do that. What kind of content did we want those folks to have? What kind of cost could we bear related to that educational component? We really started by making sure that our primary care service line and our primary care providers were into the method that we had thought we would try to do. So we presented it to the primary care service line. Those individuals were eager to support it. We looked at educational components. We looked at where the interest laid. We looked at what diabetes centers had to offer and how our hotspots were. We looked at the amount of individuals who had diabetes in certain areas, and we focused on those. Next thing that we did was we really looked at the identification of providers. When we had gone out to see the initial providers, there were a number of them that were very interested in providing diabetes education for their clients, but were unable to put anything specifically together. One of the things that we discovered is that there is, and I think Leanne addressed it as well, there is competition amongst providers. And so we wanted to not only be attentive to that, but we also wanted to explore some of the educational format options. So we had 4 models of care that we actually ended up using. One of them was surrounded by mid-level providers that did the education. One was to establish a new diabetes center out in a rural area. The other was to provide a CDE actually buried within the clinic. And so we looked at all of those options and were able to put in play all of the options that I just spoke about. We saw that those educational opportunities really fill the need directly within the community. Each community really had a different approach to that, and that was important for us to see. We looked at the development of an overarching program. So rather than just going out and having those individuals who are going to do the education pick up that education in one specific format, we decided to do a contract arrangement with the International Diabetes Center up in St. Paul, Minnesota. I had been through that program, and they offered a good primary care focus and management, as well as 2 advanced CDE programs. And so we looked at developing an overall guideline associated with all the programs that we initiated to make sure that there was consistency and standardization of materials used, as well as the education of the providers that we were going to do. We took that to the areas of providers and allowed them input related to what we were going to use for materials and how we were going to standardize that, as well as a discussion related to the education that those particular educators would be given. We developed a guideline for that pilot. For instance, we wanted that education to be education only. Evaluation and management were left entirely up to the providers. So regardless of the model that we chose, whether it was the mid-level providers down in Nebraska or the folks in Spencer, the purpose was education only. It was the provision of a standardized educational format. They presented that to the individuals, and that way we could control the outcome. We standardized materials. We asked them to only use the materials that we had rather than the materials that came from the various detail companies that came into their clinic settings. We actually went to each of the clinics that were going to be involved and produced these guidelines and had them accept them, as well as accepted through our regional directorship and the quality leadership. We, as a group, allowed the regions to develop the funding options. One was funded through a grant through the American Hospital Association. The other was funded through just through regional directorship. So each of them developed what they thought they could do for funding. Those funding options were discussed with the primary care, so they understood how it was. We also discussed at that time how they would do the billing and made those steps in that direction. Each of the individuals who participated in this program were educated at the International Diabetes Center in St. Paul. They took a minimum of 1, and most of them took 3 courseworks associated with education, so that we had some consistency in what we produced. Recruitment was not difficult. Providers were eager to have somebody who would take the time to sit down with their patients. We had a couple of communities that had health fairs where they introduced it. We had a lot of self-referral. The mid-level providers started with their own clients. And we also did allowed the communities to do some flyers and some printed notices. So we had excellent participation in that recruitment source. We made sure that each of those individuals had the opportunity to see what it produced. So one of the things that I think it's important for us to understand is that each of these sessions that these mid-level providers had were approximately 60 minutes in duration. You and I both know that having a provider during his daytime be able to allow an hour presentation, an hour educational is impossible. So we found that the average number of visits for each individual was about 1.4 to 2.1. So only 1 to 2 sessions were provided to each of these individuals. We collected their names, we collected the referral source, we collected both pre-hemoglobin A1C and post-hemoglobin A1C of at least 6 months, and then calculated the changes in the A1C value. So you've got 1 to 2 sessions with that individual educator. You measure pre and post A1Cs, and that produced a significant improvement in overall A1C values. The program in Spencer did a little bit different. They were funded through the American Hospital Association grant, and they used an incentive program so that they created 5 different areas that they wanted their participants to exceed in, and so those were developing a log so they could see home glucoses. They had to see the provider a certain number of times. They were done foot care. So we had some incentives associated with that. But interestingly, what we figured out was that after the first couple of incentives were no longer the big deal. It was more about the relationship that they developed with their educator and with their primary care that really drove the goal. We were extremely, extremely pleased with what we saw in that period of time, regardless of which of the 4 models of education were provided. We saw a drop in hemoglobin A1Cs from 1.5 to 2.1 points. That's phenomenal. Certainly beyond what our expectations had been. It certainly proved to us that education of any sort spent with a patient provides significant improvement in measures. And so we've been blessed with spreading that model of care. We have APPs now in Freeman. We have an APP out in Chamberlain. Spencer has continued their program. Nebraska has continued their program. So we've been have seen that the educational model is phenomenal. I think the secret to this is that we developed a model of care, standardized the materials used, standardized the education our providers gave, and that certainly made a difference. You know, the cost of education is certainly consistent on the commitment by management. You know, I think what we've proved through our primary care service line staff is that they're extremely pleased with that, and that overall the expense of education for our educators has been small compared to the dramatic drop that we've had in A1Cs. One of the things that we figured out was that follow-up is going to be extremely important, and I'm not telling you anything you don't already know, that all of those wonderful improvements are dependent on relationships and follow-up. And so our Spencer clinics and our Nebraska kids routinely call the patients at home, ask them about how their home glucoses are, make sure that they're coming in on a regular basis, making sure that they have their medication, so that we really know that that follow-up has a big importance. We've seen, since the Spencer project is still in process, that with that, we have continued to see improvement in the hemoglobin A1C. So not only initial drop of A1C, quite dramatic, but also a continuation of improvement in the A1C. So we'll continue to follow that progress and make sure that that goes forward. So, you know, I think this is really what we were after. Is we were really after trying to prove to ourselves and to everyone else that education matters, that involvement with the patient and sitting down to provide them education around self-management and glucose testing and the need for eye exams and foot exams, all of those things dramatically improve our measures, and by improving our measures, we improve our patients' lives. So it's been fun. I look forward to continuing the process. Thank you, guys.
Thank you, Sue. And, you know, so many of our patients have multiple comorbidities, and it's really common to see both diabetes and cardiovascular disease in these folks. So it's important, I think, to remember that our patients are dealing with these multiple disease states and that those can really greatly affect their treatment options and their care needs. And so it's really important to keep that in mind when we're looking at their quality improvement initiatives and education, keeping the patients educated about, everything that's going on with them makes such a huge difference. So I'd like to take a minute again to pause so we can have questions and comments with what Susan reviewed today. So just a reminder, you can go ahead and type in the chat box or press *6 to unmute your phone. And I can start us here too. Were there any particular challenges that you found while you were getting started and moving through this whole process?
I think probably our biggest challenge was to make sure that we were attentive to the primary care providers' ability to do the evaluation and management. I think initially that was our biggest concern, was that we didn't want to put our mid-level providers in a situation, and I think that was probably our biggest concern, and that worked out. The way we developed the pilot, that worked out really well.
That's great. So were there any surprises that you came up against the road, any roadblocks that you weren't expecting, or any surprises with the outcomes that you encountered?
I think we were well enough prepared that we didn't have a lot of barriers. I was quite surprised by the dramatic reduction in A1C. We had some individuals that the mid-level educated that dropped by 3 full points at A1C in a matter of the first checkup follow-up. So that's a dramatic improvement. We've always talked about how well education works with patients, but I think I was surprised by how good that looked. I see a question about the details of the coursework, and so I would reference you guys to the International Diabetes Center professional education format. They have a coursework called Diabetes Management and Primary Care, and then they have 2 courseworks, one as a CDE prep and the other is an Advanced Certified Diabetic Educator prep that are available.
Thank you.
Yeah.
Any other questions or comments? Okay, seeing none. We covered some really great information today, but before we wrap things up, I just want to briefly mention that there's going to be one more webinar focusing on quality improvement taking place within the next couple months here. This webinar will showcase the new quality improvement toolkit that's being created in partnership with the Cardiovascular Collaborative. And during the webinar, we will walk through the contents of the resource and show you how to navigate the online document. We're still in the final stages of drafting that toolkit, but please stay tuned. The date for the webinar is still being determined as well, but it should be released soon. And then also just a reminder that if you missed any of the previous webinars, you can view the recordings in the webinar section on the Quality Improvement Resource website. So in closing, I'd like to thank you for joining us on this webinar. I'd like to thank you for your interest in quality improvement and for all the work that you do to help keep our South Dakota residents healthy. If you'd like to find out more about the QI resources that were discussed today, if you're interested in joining the Cardiovascular Collaborative, or you'd like to learn more about potential opportunities to partner on QI initiatives, please feel free to contact me using the information listed on the last slide. Again, thank you, and I hope everyone enjoys the rest of their week.